Hi, my name is Mackenzie Patrick, and this is my final video practicum on shoulder impingement. The region of assessment is going to be the glenohumeral joint, and the impairment is going to be shoulder impingement syndrome, or SAIS. This is going to be characterized by rounded shoulders, a forward head posture, and scapular asymmetry, leading to reduced subacromial space and mechanical compression. So to examine what we need to fix, we're going to look at a static posture assessment. So in doing this, we're going to have our checkpoints, the first being the foot and the ankle, then the knee, the lumbopelvic hip complex, or LPHC, and then the head or cervical spine. So in the foot or ankle, there was some observing of mild external rotation or pronation of the feet. And then there's also some slight lateral pelvic tilt. This is mostly due to a muscle imbalance of potential tightness in the quads or hip adductors, and then weakness in the opposite hip stabilizers. But what we're going to focus on today is going to be those shoulders. So here we can see that there's a slight deviation of 2 degrees within the shoulder height, and then there's possible mild overactivity or tightness in the upper traps or the scapula. Furthermore, looking at the head and cervical area, we can see that the head is aligned with a slight deviation, which is possibly due to minor tightness in the upper traps or the sternocleidomastoid. So moving on to the lateral view, we can see that there are some foot and ankle differences, with the feet appearing to be neutral with a slight forward lean. And then we can also see that these knees are going to appear neutral without any like hyperflexion or flexion, but we do see that slight significant interior pelvic tilt. But looking at the upper extremities, we can see that they have noticeably rounded shoulders and forward positioning in that upper body. This is suggesting that we have overactivity in the pectoralis major and minor, anterior deltoids, and latissimus dorsi. And then additionally, some underactive muscles that we could be seeing here include mid and lower traps, rhomboids, sertorius anterior, and posterior deltoids. So starting at the lower extremities, we can see that there is some foot and ankle mild external rotation. We additionally can see that their knees appear to be very neutral and that there is still a significant interior pelvic tilt observed. But focusing on those upper extremities, we can see that one shoulder is positioned to be notably higher than the other, and this asymmetry suggests muscular imbalances, likely tightness in the upper traps and levator scapulae on the elevated side, and then potential weaknesses in that mid and lower trap muscles. And then finally, there's a slight lateral tilt of the head, indicating that there's some possible cervical spine imbalances and compensatory muscle tightness in the neck and shoulders. So during the overhead squat test, we are specifically observing the upper body to assess movement patterns related to shoulder function. So one key compensation that we're looking for is arms falling forward, which is going to suggest a tightness in the latissimus dorsi, pec major and minor, and the teres major, which are all muscles that can contribute to altered scapular positioning and reduced acromial space, worsening impingement symptoms. Another important observation is shoulder elevation during the squat, which often indicates overactivity in the muscle upper traps and levator scapulae, combined with underactivity in the mid and lower traps, which is the sartorius anterior. And these imbalances affect scapular stability and control, which are critical factors in shoulder impingement. Additionally, excessive forward lean of the torso may be noted, which can lead to shoulder strain as the body compensates to maintain the balance. But focusing on these 3 body compensations during the squat, we can better identify these dysfunctions contributing to shoulder impingement to come up with a better corrective strategy. So here throughout this video, we can see that her arms are consistently falling forward. She's unable to keep them above her head. Luckily, her back is remaining flat throughout the exercise, and there doesn't seem to be much shoulder elevation, while there is a little bit that we can see on the lateral view and the posterior view. This is indicating that some overactive muscles might be the latissimus dorsi, the pec major and minor, and the coracobrachialis, as well as underactive being the mid and lower traps, rhomboids, and rotator cuff. So here we can see we're doing the horizontal abduction test, and this purpose of this is to assess posterior shoulder mobility and scapular stability. So then we're going to identify here whether there's overactivity in the upper traps and then underactivity in the lower trap or sartorius anterior. So we're going to have the patient stand up facing the wall, shoulder width apart, and then hand placed flat against the wall with their shoulder height, arm fully extended, as we can see here. We're going to want to make sure that they're maintaining a neutral spine with their chin tucked and their core engaged. Execution of this is they're just going to slowly slide the arm horizontally across the wall, keeping their hand and elbow in contact with the wall and observing the shoulder during the movement. So from this, we can see that there is a significant shoulder elevation, which is going to go ahead and indicate that overactive upper trap with underactive scapular stabilizers. So here we're looking at the rotation test. The purpose of this test is to assess thoracic spine mobility and rotational control, as well as identify mobility restrictions or stability issues affecting functional movements. So here we can see that as she's doing this, both of her shoulders are shrugging upward during the rotation, and it's suggesting that there's an overactive upper trap and poor scapular control. Here we're looking at the shoulder flexion test, which is assessing the mobility of the glenohumeral joint and flexibility of the associated muscles, such as the lat dorsi, the pec major, and the teres major, as well as the thoracic spine. During this test, the client is raising both of their hands overhead while keeping the spine in neutral, and elbows are going to be extended. The key things to look for include that the arms cannot reach overhead to align with the ears, which is what we are currently seeing here. She has a really hard time bringing those hands all the way over her ears. This is indicating a tightness in the lat dorsi, pectorals, and thoracic spine stiffness. So here we're going to be doing a manual muscle testing, testing the latissimus dorsi. So we're going to go ahead and apply pressure, and I'm going to push down and you're going to push up and resist me, all right? And go ahead and push up, resist me, resist me. So after we were doing the manual muscle testing, we determined that she had a score of a 3. She had full range of motion against gravity, but a really hard time giving resistance and getting full range of motion when I would push down on the arm. So here we're going to be testing for shoulder external rotation. So is what we're going to do is I'm going to be pushing inwards and you're going to be resisting me and trying to push outwards against the position, right? So go ahead and try to hold this position out. Good. Good. Alright, good. So here we saw the same thing that we saw in the last video. She had full range of motion against gravity, but as soon as we started pushing and giving resistance, she was unable to withstand that. Sit first. Okay, so this one we're going to be testing the internal rotators. So we're going to go ahead and I'm going to push out towards this way, and you're going to try to keep your hand in that same position where you're pushing me. Okay, go ahead and push back. This is the last manual muscle testing that we did of the shoulder internal rotation. Here we saw that there was full range of motion against gravity, but no resistance, therefore getting a score of a 3. Okay, so for our testing, we've concluded that she probably has an overactive latissimus dorsi. So we're going to first start by inhibiting that muscle. So we're going to start in a position by having her leg on her side on the floor. We're going to place a palm under the armpit, align with the side of the rib cage, and then you're going to extend your bottom arm straight over your head. Then our palms are going to be facing upward to stretch out the latissimus dorsi, and you're going to make sure that your legs are comfortably bent to balance. Then from here, you're going to slowly roll forward and backward to find the tender spots on the right areas in that position. So you're going to come front, so you're going to up. Go ahead and keep your head up. Once you find a top tight spot, you're going to hold it for 20 to 30 seconds. So the purpose of doing the foam roll was to inhibit the overactive muscle. We're going to want to remain relaxed and roll out the desired areas, resting on the tender spots for about 30 to 90 seconds in inhibition phase. The reason that we're doing this is that the latimus dorsi can often become overactive and tight, especially in individuals with upper cross syndrome, which this one has. This allows for us to release fascial adhesions and decrease the tone, which will restore proper movement, as well as prepare for activation exercises, because as we decrease the lat tension, foam rolling makes it easier to activate the underused muscles like the lower traps, the sartorius anterior, and the rotator cuff. Additionally, lengthening the latimus dorsi through foam rolling contributes to better scapula position, upright posture, and more efficient force transfer.
Okay, now that we have inhibited that latimus dorsi,
So here we want to activate and strengthen the shoulder external rotators. This is going to be part of the activation phase. We're going to have one set of 4 reps, and then they're going to be 4-second isometric holds at 25%, 50%, 75%, and 100 maximal voluntary contraction, and we're going to want to rest in between 2 seconds in each of these. External rotation cable pulls are critical for activating and strengthening the rotator cuff muscles, specifically the infraspinatus and the teres minor. These muscles are responsible for stabilizing the humeral head within the glenofossa and controlling the external rotation of the shoulder. In cases of shoulder impingement, weakness in the external rotators leads to poor joint centration and altered shoulder mechanics, increasing the risk of compression within the subacromial space. So by activating the external rotators through controlled cable pulls, we enhance shoulder stability, improving scapular positioning and preventing further impingements.
so for this next exercise, we're going to be doing activation techniques. So it's going to be isolated. So we're going to practice some external rotation. So we're going to take it and we're just going to go back and come in. We're going to want to make sure that we don't flare our elbows like I just did. Back in, stop it in here. And we're going to do it. Make sure not to flare out your elbows. Bring it in. So lastly, we're going to do an integration technique, which is going to incorporate all the things that we just did. So in order to do this, we're going to do an integrated dynamic movement for the arms falling forward, meaning we're going to do a squat to row and stand. So we're going to come back, we're going to squat, we're going to row and come up, making sure that we're not elevating our shoulders at all, and we're going to continue to do that.
Lastly, we have the integration, which is a squat to row. In this, we are combining that lower body strength, which is the squat pattern, with the upper body postural control row pattern. This is going to reinforce that core stability, scapular retraction, and dynamic postural alignment. This is going to occur for 3 to 5 days per week, 1 to 2 sets, and 10 to 15 reps in each set. We're going to want to make sure that each rep is 2 seconds of isometric holding, and then the end range is 4 seconds eccentric. We're going to want to make sure that this is integrating the posterior chain activation, which includes the glutes, hamstrings, mid and lower traps, and rhomboids into functional coordinated movement, as well as correcting postural compensations seen in upper cross syndrome by strengthening the scapular stabilizers and lengthening the lower body mechanics. This is going to mimic real world events such as lifting, pulling, standing to make sure that we're reinforcing those movement patterns beyond the isolated muscle training. And here are the references.